We show up, patient is breathing hard, oxygen saturation 75, patient starting to turn blue. What do? Well, number one, apply oxygen, both to the upper airway and to the tracheostomy site itself. Now, you're not going to hurt anything by doing that, but we might help. If the patient's no better, we go ahead and remove all the caps and all the appliances from off the end of the tracheostomy tube in order to clear the thing. We remove the inner cannula from the tracheostomy tube. You can inspect it if you want at this point, but getting it out is the big thing. At that point, we're going to try to pass a suction catheter through the outer tracheostomy tube. And if we are able to pass it, then we have shown that there is a patent airway, and it's less likely to be the tracheostomy itself that's causing the problem. If we're unable to pass the suction catheter, we're going to deflate the cuff to allow air to pass on either side of the tracheostomy tube if that is something that has not already been done. And then if the patient's still not better or at least tolerable, we're going to remove the outer cannula, go ahead and pull the tracheostomy tube itself. If the patient's still not better, we're going to do a combination of either trying to ventilate from above or from ventilating the stoma. And either one will probably work. You just need to pick one and do it. It's probably a little bit easier if they have a tracheostomy and not a laryngectomy per se to ventilate from above and occlude the stoma than try to ventilate through the stoma and occlude the mouth. At that point, if we've not made any progress, we can try to intubate the stoma and then try to intubate from above, knowing that in most cases there may be some difficult anatomy that caused them to get the tracheostomy in the first place, and this may be a very difficult airway. So if we have a tube in place and it is the tip of the tube and the balloon are down past the stoma itself, then the airway is good, but we're going to confirm that by using end-tidal CO2 and confirming that we have a waveform. All right, so that's the patient in respiratory distress that has a tracheostomy, and you can follow that pathway pretty specifically most times. Now, again, there are little things that can happen, but generally speaking, this will give you an algorithm to take care of most of these folks. Again, if you can pass a suction catheter through this thing, then you've pretty well proved that it in itself is patent. Generally speaking, knock on wood, that something weird hasn't happened. This is probably patent at that point. There's something else going on with the patient. So the other thing that happens outside of respiratory distress with tracheostomies is bleeding. You walk into somebody's house and across from the patient there is this big spot of blood on the wall and it looks like somebody's shot a deer or something like that. Bleeding from tracheostomy sites and from tracheostomy tubes can be fairly scary, and most of the time it's not anything that you really have to worry about. It'll be relatively self-limited or relatively small in amount, but it's tough to sort out in the initial stages which one is the really bad one and which one is the sort of minor thing. So again, most of the time bleeding from tracheostomy sites is going to be from little bits, even though it can be relatively brisk and cause a mess and really freak people out. Most of the time it's going to be of a relatively small quantity and from something like a little bit of mucosal irritation or a little bit of granulation tissue that's built up around the edge of the tracheostomy site. ENT can usually come in, see these things, they'll go and they'll look and make sure there's no other sources of bleeding, and then either do a little cautery or tamponade that thing off, maybe a little stitch across the top of it, depending on what it looks like, and everything looks good at the end of the day. They tell them to go home and come back if you have any further bleeding. That, again, takes care of most of it, and that's what happens the majority of the time. However, it's tough to tell those little bleeds without actually taking a look from the big bleed. And what's the big bleed? The big bleed is this thing called a tracheonominate fistula. So the way that this happens, this is a really scary, often rapidly fatal event when this happens. So what is it exactly? Here's your trachea, and this is sort of the upper mediastinum here. You have your trachea, and right in front of it passes the innominate artery. And if you don't remember the innominate artery, it's the first branch off the aorta that turns into your right carotid and your subclavian artery on the right side. So it kind of feeds the upper right quadrant of your body. So, again, it's arterial. It's right off the aorta. It crosses right in front of the trachea. The thing about it is that where the balloon sits on most tracheostomies, usually it's right about there is where that crossing is. if you've had a tracheostomy for a long time, the edge of the balloon or the edge of the cannula itself can sometimes erode into the soft tissues of the mediastinum. So it erodes through the trachea, sort of like a bed sore, basically. Just over time, pressure or continued irritation will erode through the trachea, through the soft tissues of the mediastinum, and directly into the innominate artery itself. When that happens, sometimes you get a little bit of initial bleeding, followed by a big bleed a couple hours later, or sometimes it just lets loose. So this is, again, the cross-section trachea sitting right here. Here's the balloon. Here's where the innominate artery sits. You can imagine if you put a little hole in one of the big arteries that comes right out of your heart, that you start to get pretty rapid amounts of blood loss. And it can either go down into your lungs and you cough it up, or you become hypoxic and basically aspirate on it, or it could come out the top primarily, depending on where the hole is located. So you can imagine that this is a bad thing because it is bleeding into an empty space that doesn't have a good way to tamponade otherwise. What do you do about these things? The first thing that's recommended is that if you can get a tracheostomy tube with a cuff on it, assuming that there is one in place, the first thing they recommend is actually to take and fill up the cuff on that balloon, and don't only fill it to 30 mLs of air or whatever it's designed to do. Go ahead and keep putting air in it beyond that, so it's pretty tight. Double that amount of air, something like that. What this should theoretically do is put pressure on the bleeding site and help to compress the innominate artery and hopefully tamponade things off that way. This gives you a little bit of time to get the patient to surgical care. Now, if that thing moves around a lot, or if the cuff deflates, or if it gets a hole in it, or if the cuff bursts, then you're in a bad state again, and bleeding will continue. The other thing that you may be able to do is this maneuver. So what you're seeing here is they have intubated the trachea from above. This may or may not be possible for you. And then this person has snuck their finger through the stoma and behind the sternum itself, and they are smushing the innominate artery with the hole up against the back of the sternum and putting direct pressure on it. Now, you can't keep this up for very long because, again, right side of your body, no blood coming out there. That's sort of an issue. So if you manage to fully compress the thing, you've given them another set of problems to deal with. So you have to go quick if this is something you're going to do. But if you can tamponade the thing, then you may be able to get a little bit of control on it, at least long enough to get them to an operating room. One thing that you often won't see, though, is that the ET tube in the trachea from above. And a lot of times, most of us aren't really comfortable digging in down here and finding this artery and putting your finger on the soft tissues through the neck itself. So what you're probably going to end up doing if you try this maneuver is putting your finger into the stoma all the way into the trachea and then compressing up against the back of the sternum, grabbing and pulling that way and trying to compress it that way through the wall of the trachea itself. This may or may not work. If it does, it again is something that you are going to have to hold in place for a while, and then you've got the problem of I've now got my finger in the person's trachea. It's going to be hard to ventilate through that. So again, another host of problems. These are temporizing measures, and as soon as you identify that this may be an issue, you need to call ahead to the hospital so that they can go ahead and mobilize a surgical team, because all these guys will need to go up to surgery, usually in a relatively quick set of events, because all this stuff is, again, just a temporizing measure. So, to sum up, dealing with tracheostomies can be scary, but if you have an algorithmic set of rules to kind of use to take care of this, sort of like you have for ACLS, do this first, things get a little bit easier. When we find somebody in respiratory distress who has a tracheostomy, number one, we're going to attempt to oxygenate them using just non-rebreather oxygen over the mouth and over the stoma to try to increase the chance that they will get some oxygen down into their lungs. We're going to ask, is the tracheostomy tube patent? And then we're going to prove that's the case by taking all the junk off of it, taking all the appliances and everything, taking out the inner cannula, and then passing a suction catheter down through the tracheostomy tube. If you are able to pass the suction catheter all the way through the tracheostomy tube and, an inch beyond, most likely the tube itself is not so much the problem. There may be something else related to it, but the tube itself does not appear to be the problem. So consider things like CHF exacerbation, COPD, pneumonia, pneumonia, pneumothorax, all that stuff. If we can't pass a suction catheter through this thing, even after taking all the stuff off, then a non-functioning tracheostomy tube in the right spot is doing nobody any good. So DC that thing, get it out of the way, and then you can attempt to ventilate or intubate either from above or from the stoma, keeping in mind that if you've got a laryngectomy, ventilating from above is not going to work because there is no connection and you'll only insufflate the stomach with each breath. Keep in mind that bleeding tracheostomies are often not that big a deal, but are sort of impressive to see and can be very distressing. And you still can get some bleeding and some hemoptysis when this happens. You have to take all of them seriously, though, for fear that this could be the early parts of a tracheonominate fistula that you're seeing. So if you see significant tracheal bleeding, not just a little bit, not just a dribble, but cough, blood, cough, blood, cough, blood, cough, blood, all over the place, patient's getting hypoxic, then this patient may have a tracheonominate fistula. It's usually a safe bet to go ahead and hyperinflate the cuff. And if that doesn't work, if you get rid of the tracheostomy cannula itself, you can put a finger into the stoma and then attempt to find the hole and then hook your finger forward and compress the artery and the hole up against the back of the sternum. So hopefully that gives you a pathway to sort of use if you are dealing with a tracheostomy emergency. If you have any questions, certainly email us. These can be real scary and not all the time do we deal with them. So if you have any questions, hit us up, let us know. And otherwise, this is Walt Lubbers, EMS Grand Rounds. Thanks for your attention, and we'll see you next time.